Okay. Uh, Seeing a bunch of folks come trickling in here. I think I'm gonna go ahead and get us started. Hello, and thank you again for joining us for our March Co-APCD Research Showcase. We have some panelists here with some fascinating and exciting topics to talk about, to show how they are using the Co-APCD in the research they are doing. My name is Sarah. I work at the Center for Improving Value in Healthcare, as a digital communication specialist. I'm going to just take us through real quickly an overview of who we are at Civic in the Colorado All-Payer Claims Database, and then we can get you into what you're really here for and hear from our panelists today. Just a quick look at our agenda. Like I said, I'll take us through a quick overview of Civic and the Co-APCD. They will get into our presentations, and then at the end here, we're going to wrap up at 1:30 today, and with time allowed, we'll close out today with some time for Q&A and discussion from all of you. So first, just some housekeeping along with that. Please note that all of your lines are muted, but you are free to type questions as they come up during the presentation into the little chat box. And then at the end of each presentation, we'll go through and get to a couple of questions that our panelists can address. So please go ahead and type your question into the box at any time. Please also note that this presentation is being recorded, and it will be made available on Civic's website at a later date in a couple of days. If you would like to revisit it or revisit the slides or anything like that, send it along to your friends, maybe. I don't know. Overview of who we are at the Center for Improving Value in Healthcare, or CIVIC. We are a nonprofit. Our mission is to equip partners and communities in Colorado and across the nation with the resources, services, and unbiased data needed to improve health and healthcare. We have a vision that everybody has the opportunity to be healthy and access to equitable, affordable, and high-quality healthcare. As I mentioned, we are a nonprofit. We are independent and objective, no political affiliations of any kind, and we are service-oriented. Our partners who we work with are kind of run the gamut across the state and across the country, folks who are working in the healthcare space. So we work with individuals, businesses, and community organizations, anyone who is working to lower healthcare costs, improve care, and make our state healthier. So that runs across the spectrum. We work with clinicians, we work with policymakers, we work with health plans and health systems, employers, nonprofit organizations, and as you're going to see today, we work a lot with researchers. So just a quick overview of some of the products and services that you can leverage from the Colorado All-Payer Claims Database. We release data in two ways. We do public releases, which come through reports that are available, public reports available on our website on a variety of issues to identify opportunities for improvement in your community. So we have a lot of interactive reports and publications you can go look at. We look at topics including prescription drug rebates, alternative payment model adaptation. We have a couple of exciting price transparency tools. Our staple one being called Shop for Care, where you can see facility costs for a number of procedures at different facilities across our state. There's a lot of exciting tools. I can't even go all of them. There's a real variety, so go check those out. And you can access the underlying data for a majority of those. We also do licensed releases of co-APC data, where you can receive custom or standard reports or data sets for whatever your question may be that you're trying to answer, whatever your purpose may be. So we also do, in addition to those analytic services, we also have evaluation and research programs and do a lot of community engagement across the state. And what is in the Colorado All-Payer Claims Database? We have over 1.3 billion claims now that go all the way back to 2013 through 2025, actually, as recent as a couple of months ago. We have 33 payers, including Medicaid, Medicare, both FFS and Advantage. We have trend information going all the way from 2013 through current day. Our claims account for approximately 70% of covered lives in Colorado, or 5.7 million lives. Some things that are not that you cannot find in the co-APCD. There's not many, but we do have a few couple of small gaps. That is for anyone who's insured through federal programs such as VA, TRICARE, or Indian Health Services. Uh, Obviously, anybody who is not insured, or if a claim is not generated, they are not included in the database. And then finally, about half of ERISA-based self-insured employers are not included because they are not mandated to report to the co-APCD. So we work on a one-on-one basis to try and get some of those, have some of that included, but it doesn't always work. Oops, and I jumped a little bit forward. So let's get into our showcase presentations, what everyone's really here for today, so I can stop yapping. We're going to start off with Nancy Fang from the University of Colorado Anschutz. And then we have Mariana, Rhonda, and Dagmar and Aaron are all here to present after Nancy. So we'll get started and I'll turn it over to Nancy whenever you're ready. Take it away.
Awesome. Thank you so much. We can go to the next slide. So I am so honored to be presenting some of my work with the Colorado APCD, looking at quantifying life-threatening pregnancy complications in patients with chronic health conditions in Colorado. As Sarah mentioned, I'm in the Department of Obstetrics and Gynecology Division of Complex Family Planning on Anschutz's campus, and have just been really lucky enough to get this data and work with it over the last few years. Next slide. So some funding acknowledgement. I forgot sillily to recognize the Colorado APCD for providing scholarship funds to fund some of this work, as well as a current K-12 that I'm on, as well as our academic enrichment fund. Next slide. So briefly about me, just because this was in the previous presentations. I was born and raised in Massachusetts, but have gone all over the country for my training. Most recently, I was in New York for my family planning training, and then came back to Colorado where I'd done residency before, and now there as faculty. Next slide. So a little bit of background about my why I wanted to do this project. So I work a lot at the intersection of maternal health and morbidity, and providing reproductive options for patients. And we know from prior research that at baseline, people in general, with or without chronic conditions, are 14 times more likely to die during childbirth than during an abortion, and also are at increased risk of morbidity. And that those with chronic health conditions or pregnancy-related diseases face even greater risk. Next slide. My objective in using this data was to compare the prevalence of severe maternal morbidity as defined by the CDC, and maternal mortality in pregnant patients with pre-existing health conditions compared to those without pre-existing health conditions delivering in Colorado. Next slide. This was looking at claims data from 2018 to 2022. We included females less than 55 with a pregnancy episode. We did exclude any biologically implausible pregnancies in that data set as well. We assigned the severe maternal morbidity index based off of CDC's 21 indicator framework based off of ICD-10 codes. And then to assign chronic conditions, we base this on HCUP's chronic condition indicator revised for ICD-10. And this was looking at any claims in the prior 12 months to their pregnancy episode of whether or not they had one of the chronic conditions. And this was a binary of whether they had a chronic condition or not. Next slide. So this is a brief outcome. This was not our final cohort, but just a descriptive of the total pregnancy outcomes that we had within our database. So we had a total of 333,000 pregnancy episodes identified. The majority of these were live birth. We did have about 11% that reported any claims related to miscarriage or spontaneous abortion. About 2% we were unable to classify, but knew that there was some type of delivery. And then about between 0.6 and 1% for induced abortion, ectopics, and fetal demises or stillbirth. Next slide. When we looked at our overall SMM prevalence, we found that about 97% of the cohort did not have a SMM indicator, and about 2.76% of Coloradans did have a SMM. I will say that this is among all pregnancy outcomes and not live birth. Next slide. And then when we look at our pre-existing chronic conditions to describe the Colorado population, we saw that about 20% in our overall sample had a ICD-10 code that was associated with a pre-existing condition as defined by the CCIR, and about 80% that did not. Next slide. And then just looking at our insurance types, we have about 60% of them using Medicaid as their primary insurance, and then about 37% using commercial. We did exclude, or in the slide, I excluded Medicare or just because of a low N. Next slide. So for our results, we saw that for live births, patients with chronic conditions have an increased odds of 1.5 compared to patients without a chronic condition, and that's for mortality. And then within patients with Medicaid or public insurance, that odd is increased to 5.9. Next slide. For our morbidity, we found that there was a 1.7 time odds of morbidity compared to patients without chronic conditions. But interestingly, it seems like the odds of morbidity is attenuated in our patients with Medicaid, although based off of the confidence interval, still statistically significant. Next slide. So conclusions, patients with pre-existing chronic conditions have a higher odds of experience with severe maternal mortality and morbidity during live births in Colorado. And then my next steps in the study are to look at a cohort looking at the differences in morbidity and mortality among different pregnancy outcomes. I will add, and sorry, I didn't have this in my slides before. Could you go up just a few slides for the morbidity? Yeah, thank you. So for these, I didn't write out here what we adjusted our analysis for, but based off of the available data that we had, we did adjust for age. We also used SVI, two of the domains, SES and race and ethnicity, and we did adjust for that as well. And then I'm sorry, I don't have all of my notes in front of me, but I think there was one more thing that we did adjust our multivariable regression for. Next. Okay, so that's all I had for that presentation. So I welcome any questions.
Fantastic. Thanks so much, Nancy. I'll go ahead and give it just a couple of minutes so anybody can type any questions that you might have. Go ahead and just type it into the chat box. So I'll just give a few seconds for everybody to think about that. All right. Not seeing anything come in immediately. We can go ahead and continue moving on. Thank you, Christy. Yes, it's super interesting. If you have any other questions that come up, maybe one dawns on you in a couple of minutes, please go ahead and just type it into the chat box. And we will have some time at the end to go back and answer any other questions that might come up or that you might think of along the way. And I'll just say as well that if you have any questions that you think of later on tonight or tomorrow morning, or whatever, sometimes if you're thinking about this presentation afterward, I know I will be, then you can go ahead. You'll receive a follow-up email with an email address for all of our presenters. You can reach out to them with any other questions that might come up. Um, so that being said, I'm going to go ahead and move us along. Nancy's references, and we will go ahead and get on with Mariana. Go ahead. Whoops. There we go. Okay, now you can go ahead, Mariana. Sorry.
Thank you, Sarah, and everyone for having me. My name is Mariana. I am a PhD candidate in economics at Stanford, and this is a joint work with a fellow PhD candidate, Nick Gracely, where we look at how insurer-physician acquisitions can impact physician incentives. Could you, next slide, please? So a key motivation for this research is that over the past decade or so, there's been a growing trend of vertical integration in the healthcare market, specifically where insurance companies are increasingly purchasing primary care doctors. And this is really widespread. It's visible in the news. And today, insurers are the largest employers. The largest employer is, I think, United Health Group, at around 10% of all doctors in the US work for them, usually through Optum. And CVS Aetna is the second largest at around 5% of all doctors. And so this has generated a lot of policy maker concern. Could you click next, please? And so both the DOJ and the FTC have done several investigations, probes, and lawsuits towards insurance companies. Next. But this type of integration is kind of generically ambiguous, and there are many impacts that can be happening. And there's a lot of competitive impacts that might be at place, and there's a large literature on this. But there are also impacts within how the incentives are aligned and behaviors are changing within the integrated group. And so this is what we are going to focus on in this research. Next. Where we're basically, our broad question is going to be, how does vertical integration align incentives within the firm? Next. And specifically, how does being acquired by an insurance company align incentives between insurers and doctors? And how does it change primary care doctors' behavior? And here I want to note that when I say primary care doctors, I mean the practice as a whole. And so this may not be an individual doctor making a different action, but the practice, which includes administrative staff as well. And here we're going to focus on two main aspects of doctors' behaviors. The first comes from the fact that in Medicare Advantage, which is a big part of the healthcare sector, the government is paying the insurance company, and these payments are a function of doctors' diagnostic decisions. And so the first natural question that we ask here is, well, does being acquired change how much and how doctors diagnose their patients? And does it deliver higher payments for the insurance company? The second question is coming from the fact that primary care doctors can have a lot of influence over the overall cost of care, and insurance companies have to pay for that care, and so they really care about the cost of care. And specifically through their control over referrals to access specialist care, primary care doctors can impact the overall cost for the insurance company. And so the second question that we ask is, well, do primary care doctors change how they refer patients? And does this deliver cost savings for the insurer? Next slide, please. And you can click to the end of this slide. It's one more. There, and thank you. Oh, one back. And broadly, how do we do this? Well, we're going to leverage the Colorado all-payer claims database, which is a really rich market-wide medical claims database that's going to let us empirically study one instance of these types of acquisitions. And we're going to answer the first question of whether doctors change their diagnostic behavior and whether this delivers higher payments by conducting an event study design that let us identify how becoming integrated increases government payments to the insurance company. And here we find that on average, payments are increasing by about $1,500 per patient per year. Then to look at whether primary care doctors change their referral behavior and whether this delivers cost savings, we're going to write and estimate a model of doctor referrals that we can use to simulate counterfactual spending. So how much would have been spent, for instance, for inpatient hospital care with or without the acquisition. And here we find that the acquisition led to referrals that were on average $300 cheaper for the insurance company. Next. Here, just to briefly say, there's a large, really cool literature that we are building on that I highly, if you're interested in this, highly recommend. Next, please. And you can go to the next one. I'm going to ask you if you can click next a couple of times and I'll just have it all laid out. So next, there, thank you. And, oh, went back, sorry. So what we're going to do here empirically is focus on one instance of an acquisition, which we think is actually quite representative of acquisitions happening across the US in the mid to late 2010s. And this one takes place in Denver, Colorado in 2017. And the important fact here is that these acquisitions are not exclusive. This means that these doctors are seeing both patients of the acquiring insurer and other insurers before and after they are acquired. And this is the largest insurer in the state of Colorado. They have about a 65% market share in Medicare Advantage and 35% in commercial. And the primary care practice is really large in Denver as well. They have about a 4% of the market share, which for primary care is a lot. And the best thing about this acquisition, not only does it look like the things that we are concerned about more broadly in the policy sphere, but we have this really cool data from the Colorado All Payers Claims database. And then next slide, please. Which you've heard a lot about it from Sarah today, but basically we have an extract from this data from 2015 to 2019, where we see every reimbursed medical encounter in both the commercial and Medicare Advantage segments for about 1.5 million patients across all of these 48 insurance plans. We can identify which plans belong to the acquiring insurer, and crucially, we see very detailed procedure, diagnostic, and price information. Next slide, please. And next slide. So the first things that we're looking at is whether is this diagnostic behavior. And this arises here because of how the market is set up, where if you're over 65, you're usually choosing between traditional Medicare or Medicare Advantage plans, where traditional Medicare is provided by the government and Medicare Advantage is a private alternative. And at a high level, the way that this is set up is such that the government is going to pay the insurance company as a function of diagnoses that patients have, basically trying to say, well, if a patient is sicker, they will cost the insurance company more, and so I want to pay them more. And the way that we measure sickness is through diagnoses. But doctors control diagnoses, and so in the next slide, we can see how if the doctor and the insurance company are the same entity, then they control the diagnosis that determine their own payments. And so kind of theoretically, you'd expect here to see differential coding, which is an increase in diagnostic provision, which leads to more government payments. Next slide, please. And so quickly, the idea here is that these payments are determined by these diagnoses in the way that if a doctor provides you a diagnosis like diabetes, this gets communicated to the Center for Medicare and Medicaid Services, which constructs a risk score, which is basically a weighted sum of diagnoses and demographic characteristics. And then you're basically going to get paid a constant time risk score. And so in Denver, in our time period, it's about $800 per unit of risk per patient per month. And so because we have the claims data, we see all the diagnoses, In Colorado, we have the algorithm that CMS uses. We can just construct the risk scores. And in the next slide, we can basically see in red for Medicare Advantage patients of the acquiring insurer, both at the doctors that were bought and at other doctors in Colorado in this time period, we see a trend of increasing risk scores for these patients, which means increasing payments from the government to the insurance company. And this kind of makes sense for the acquired practice, but what could be happening in the market overall? And so in the next slide, please. What we see is adoption. There's a type of contracts that are usually known as capitation, or we can call paper-patient contracts, that can have similar impacts because of how doctors are being paid. And again, by doctors, I mean doctor practices. And because we get to observe in the data a claim level indicator for this, we can construct a measure of adoption. And so in the next slide, we can see that actually both at the doctors that were acquired, but for about half of other practices as well, the acquiring insurer is contracting with doctors in this way, where we kind of know that these contracts can generate similar behaviors. And so how are we going to measure the impact of the acquisition? Well, what we're going to do is we're going to focus our attention on patients at the acquired practice and compare patients of the acquiring insurer to patients of other insurers. Could you click next? And next again, and again. And so broadly, what we're going to do is we're going to focus on patients at the acquired practice, say that our treated group are Medicare Advantage patients of the acquiring insurer, and our control groups are patients of other insurers. And we're going to conduct an event study design where we follow people over time, and we can just compute changes in their risk, in a person's risk score over time. And so in the next slide, we can see that in our event studies, how the acquisition for these patients at this doctor led to an increase in risk scores from 20 to 37% over this time period. Next. Which translates into about $1,000 to $1,800 per year in increased payments per patient per year. And so this is a quite substantial increase. Next. And next, sorry, and next again. Oh, the important thing to keep in mind here is that, well, there's an increase in diagnostic provision that's coming from the acquisition. Is this good or is this bad? Well, for the government's perspective, this is an increase in taxpayer costs, which we may be concerned about. And we don't find any evidence we find some evidence of a little bit of increased treatment for these patients, but much less of an increased treatments than the increase in diagnoses. And so it doesn't look like the increase in diagnoses is being accompanied by a commensurate increase in treatment. So it doesn't seem like the health benefits are being realized from this increase in expenditure, at least suggestively. Next slide. And the next again. And the second part of this, perfect, thank you, is that both for commercial plans and Medicare Advantage plans, because these insurance plans have to pay for all of the care that patients get, and primary care doctors control access to hospital and a specialist through their referrals, if they steer their referrals towards cheaper specialists, for instance, they might generate cost savings. And so this is the second thing that we're going to look at. In the next slide, you can click a couple of times again, I'm sorry. And one more, I think. Oh, one less, sorry. And so we're basically going to write down a model of referral decisions where doctors are going to trade off the expected cost of a visit, the distance, and the quality of a hospital or specialist. And we are going to estimate this model. Kind of the first thing that we need to do is estimate what the expected cost is in the next slide. Where we can basically use the fact that the Colorado Paris claims have all of this detailed price data to construct a cost index for every hospital, service, period, and insurer. And we do some technical controls here, like a closed formally borne out correction and a hierarchical empirical base shrinkage to reduce noise. But then in the next slide, we're basically going to do a very similar empirical strategy to before, where we compare how these group of doctors refers patients differently depending on their insurance company, basically comparing patients who are in one group or the other. And with our estimated model parameters, we can simulate what spending would be with or without acquisition, and then that comparison yields savings. And so in the next slide, we can the conclusion from these results is that for patients in the commercial segment, we actually find that referrals are being steered towards cheaper care. We have savings of about $300 per referral in inpatient referrals, and in the outpatient setting of about $26. But we don't find this type of reduction in Medicare Advantage, although this is not surprising because there's not really that much scope for having savings from sending patients towards cheaper hospitals in Medicare Advantage. Prices are a lot more similar across hospitals here. And an interesting thing is that these contracts that we saw descriptively generated increases in payments from the government as well are not generating savings in costs, although they theoretically also could be. The next slide to just wrap up. Next. We find that in fact we see an increase in diagnoses that generates an increase in payments of about $1,500. We also see some cost savings from referrals, but something that's an important thing here that we haven't fully explored yet is, well, what are the overall impacts on patient health? So we have some exercises on emergency room use, and we're looking at other exercises to get a better picture of what the impacts are on patient health as well. And the last thing that I want to note next is that because contracts can deliver similar impacts, it is important to think about the interaction between contracts and acquisition if we're trying to think about policy interventions in this area. Because people often say, well, you can just block an acquisition, and if contracts are there, then that might not be an effective policy tool. And so that is something that we are thinking on future work to address as well. Thank you very much.
Awesome. Thank you so much, Mariana. I really appreciate it. That was super interesting. Going to go ahead and take a peek here and see if we have any questions pop up for you in the chat. From Amanda, how do you identify the acquired practices?
So this is one doctor group that was acquired that I kind of knew from the news basically, and then I basically used the NPI link that Civic has and some historical records of this to assign doctors to their practice, basically using the in the NPPES business mailing address, which I have checked in different places, is very similar to doing the TIN linkage, which I don't have the information to do here, but it seems it's as best as I could find a way to match them. Yeah.
That seems to work. Let's see, Dr. Keller says you answered his question during the presentation. Awesome. I'll just give it a couple more seconds see if any more questions here trickle in. And then we can move on. Rhonda will be our next presenter. Just give everybody a chance to process. I know it takes me, it's a lot to process for me, but I am not that smart. So see if anything else comes in. Awesome. And then if anything else does come up, once again, please go ahead and just type it into the chat. Just be sure to specify which presenter it's for, and we will go back through at the end and see if there's any questions that we might have missed. So with that, I am going to go ahead and turn it over to Rhonda. Go ahead.
Thank you so much. We can go on to the next slide. All right, so my name is Rhonda West, and I am with the Center for Public Health Innovation. And today I'm going to be giving a brief overview of the Colorado Sickle Cell Disease Surveillance Program, or SCDC, as it's known. And this is a program supported by the CDC. This presentation is going to focus on our 2020 data and what it shows about the population living with sickle cell disease in Colorado, as well as how that population used acute healthcare services. So sickle cell disease, or SCD, as you'll hear it called also, is a genetic condition that affects red blood cells. Instead of staying flexible and round, these cells can become misshapen. They become shaped like a crescent or a sickle, which is where the disease actually gets its name. And these misshapen cells can block blood flow and lead to some very serious health complications that can drive emergency department visits and hospitalizations. So the SCDC program looks at data from multiple sources to try and better understand this population and ultimately support improvements in care for people living with sickle cell disease. And our surveillance work has three main goals. First, we want to characterize the population. How many people have SCD and where do they live? Second, we want to track trends over time. So that includes outcomes and healthcare use. And third, we want to inform action by providing the data that can support policy and funding decisions and improvements in care. So actually, this is not research. This is considered surveillance. And unlike research, which is usually designed to answer a specific question, surveillance is meant to describe a population on an ongoing basis. So a few points of context before I get into the results of our 2020 analysis. First is that this analysis draws from not only APCD data, but also newborn screening data and vital records. This is also our first year incorporating APCD data into this surveillance. So we were previously using EHR. But what it's done is it's really expanded what we're able to learn, but also it means that we're going to be continuing to refine our methods to see how we can use this data source. Sorry, a couple more points really quickly, if you could just go one back. So just a second point of context is that the CDC surveillance reporting uses a 5-year look back. And this is done to allow for more complete case ascertainment and more stable estimates. So that's why in 2025, we were reporting for 2020. And lastly, the third point I just want to make before we go into the results is it's very important to remember that healthcare utilization was very atypical because of the COVID-19 pandemic. Healthcare seeking behavior changed substantially. So the utilization figures that I'll be showing you today may reflect actually lower use than we might have seen in a typical year. So at a high level, our process has 4 steps. First, we apply a case definition to identify who has sickle cell disease in Colorado. And we do this using APCD claims data. We look at the ICD codes in claims data, and we look at newborn screening data. Second, we determine whether somebody actually lived in Colorado during the reporting year, in this case 2020, using APCD's geocoding. Third, we validate our findings by manually cross-referencing identified cases with clinical data to assess whether our methods are accurately identifying cases. And finally, once we've identified cases, we can better understand the characteristics of the population and how they use care. And we do this using APCD claims and vital records. And for 2020, we identified 364 people living with sickle cell disease in Colorado. And we also looked at births. So in 2020, there were 15 births, 15 babies born with SCD in Colorado. And over a 5-year period, so from 2016 to 2020, there were 68 births. And this birth count is really important to give us a sense of how the population is continuing to grow over time. This slide shows how age and sex distribution of the 364 people identified in 2020, what that looked like. So overall, the population is relatively young. 62% are under the age of 30, 81% under the age of 40, and the sex distribution was nearly even, 51% women. So one of the clearest takeaways here is that this is a young population, which has implications not only for pediatric care, but also for transitions into adult care, and longer term care services. All right, and when we look at geography, the population is very highly concentrated. About 85% of people identified with SCD live in just 4 counties: Arapahoe, Denver, El Paso, and Adams. So this concentration matters because it tells us where, sorry, capacity and care coordination can have the biggest impact. And on the flip side, this geographic, excuse me, distribution also shows us that there are people living with SCD in Colorado who may have trouble accessing care because of where they live. So the distance and the terrain. For acute care utilization, in 2020, we found that there were 423 ED visits, 217 hospital admissions, excuse me, and 1,492 days spent in the hospital. So that comes out to about 1.16 ED visits per person, zero point 0.6 hospital admissions per person, and 4.1 hospital days spent in the hospital per person. Next slide, please. And when we break this down by age group, we can see that the burden is not evenly distributed. So adults ages 20 to 49 show the highest ED visit rates and the highest number of hospital days in 2020. So while the population as a whole is young, the highest intensity of acute care use is concentrated in adulthood, and particularly in those middle adult age groups. So if you see that spike from 20 to 29, it's significantly higher than the prior age group. And I want to highlight that one in particular because it kind of aligns with what we know about transitions to care in general, which is that going into adulthood, you're not on your parents' insurance anymore. You're responsible for your own care, and taking responsibility for finding your own provider and things like that. And this can all drive increased acute care use. And this slide makes that pattern even clearer. So adults ages 20 to 49 made up 43% of the population, but they accounted for 74% of ED visits, 61% of admissions, and 71% of hospital days. So they represent less than half of people identified, but a much larger share of acute care utilization. Next slide, please. So what does this all mean for Colorado? The first thing is that resource capacity and care coordination should align with where people live. So since most identified individuals live in just 4 counties, that's where concentrated efforts may be most impactful. But at the same time, individuals living outside of those areas still need access to care that's closer to home. Second is that adult-focused strategies really matter, since adults ages 20 to 49 carry the highest ED intensity and hospital day burden. And third, just an important note is that this is just a single year, and because the counts are relatively small, um, you have to interpret them with caution. As we continue to use the APCD data, the multi-year views will be more stable and more informative. And just some limitations to keep in mind. So, since the APCD is not inclusive of all Colorado residents, some individuals with SCD may be missed because we are looking at claims data to identify people. Also, people with infrequent utilization may be underrepresented. And again, because 2020 was shaped by the pandemic, utilization patterns may not reflect typical care-seeking behavior. So looking ahead, we want to continue using APCD to complement surveillance in a few key areas. The sort of next areas that we're going to be looking at are cost of care, longitudinal patterns of care, and mental health services utilization. Those are areas where claims data can add very important detail beyond just the core surveillance counts. So that's all I have for you today. Thank you so much, and I look forward to your questions.
Awesome. Thank you so much, Rhonda. A lot to unpack there. And I'm already seeing a bunch of questions flowing in. Uh, let's see. So first from Amanda, did you factor in the life expectancy of sickle cell disease in your research?
We did not, but that is something that we are interested in looking at. So our CDC reporting does include death counts, but we have not looked at age in that way yet.
And Dr. David Keller asks, actually, the observation of high utilization in the young adult population may reflect the natural history of the disease. Shouldn't we be focusing care coordination work on prevention efforts such as gene therapy?
Um, yeah, so the surveillance effort is really meant to just provide the data. We have a big multidisciplinary team on this project that includes clinicians and advocacy groups. Um, and our piece in my team, the data team, is to provide the data to these groups who then take those actions or decide on those actions. So nothing has actually been, we did this reporting back in the end of November, and nothing has actually been set in stone as far as those next steps of where the focus area is going to be for action. But hopefully by this time next year, I'll be able to report some um, impact that this has had in Colorado.
Fantastic. Thank you, Catherine, for that comment. All right. Awesome. If anything else comes up, again, please just go ahead and type it into the chat box. I'm going to move us along to our final presentation for today. Dagmar and Aaron here are here to talk to us about APCD integration. So go ahead and take it away whenever you are ready.
Thank you, Sarah. You can go to the first slide. Thank you. Hi, everyone. My name is Dagmar Velez, and I'm here with my colleague, Erin Best. We completed this project as part of the University of Denver's Masters in Data Science program. Today, we'll be presenting our analysis on mapping hospice care access across Colorado at the county level. Our goal is to better understand where hospice services are available and, more importantly, where there may be gaps in access by combining data from the Centers for Medicare and Medicaid Services NPI registry, Medicare eligibility data, and key sociodemographic indicators, including Alzheimer's disease prevalence. Through this project, we aim to create a data-driven framework to help identify counties that may have a higher need for hospice services.
As Dagmar said, we wanted to answer the question, how do community characteristics such as those captured by the ACS correlate with the presence of hospice providers across the state of Colorado? Further, we sought to identify gaps in hospice care access by analyzing Alzheimer's disease and other county-level demographic indicators.
Next slide, please. Thank you. To provide some context, hospice care under Medicare requires that a physician certify a patient has a terminal illness with a life expectancy of 6 months or less. At a national level, there are a few important patterns to keep in mind. According to the CDC, about 96% of hospice patients are age 65 and older, meaning hospice care is heavily concentrated among the Medicare population. In the Western United States, hospice providers make up about 36% of post-acute and long-term care services, which is among the highest in the country. Additionally, roughly 45% of hospice patients have Alzheimer's disease or other dementia-related conditions, highlighting the strong connection between cognitive decline and hospice utilization. Because of this, our study goes beyond simply counting hospice providers. We also incorporate key sociodemographic factors such as age, income, education, and household characteristics, as well as Alzheimer's and dementia prevalence to better understand where the need for hospice care may be greatest. Next slide, please.
So our project draws primarily from two data sets. First, we leveraged the American Community Survey, which provided detailed socioeconomic and demographic information that we used in our study. Second, we used the National Provider Identifier Registry, which is a list of active healthcare providers across the U.S., but we focused specifically on hospice organizations operating in Colorado. And we also incorporated a couple of support data sets like Alzheimer's rates, county boundaries, and Medicare eligible accounts to build a complete picture of county level demographic and provider availability across the state. Next slide. For our data preparations, we cleaned and standardized the ACS demographic tables by removing unwanted characters, converting census tract IDs into county IDs, all before engineering features such as county level percentages and quantile-based VINs for each attribute to compare counties across the state. We then aggregated all of those ACS subtables into one unified data set. For the Medicare eligible data set, we also merged it into the ACS data set on a county level and engineered a key metric, which was the rate of hospice providers per 10,000 Medicare eligible residents. And this allowed us to compare provider availability across counties in a consistent way. Next slide.
For the NPI registry data, we used the NPI CMS registry website to scrape the data we needed. We began by collecting hospice facility information using specific filters. We limited our search to organizations, used taxonomy description of hospice, and restricted results to facilities located in Colorado. Once the data was collected, we focused on cleaning and standardizing the address information. This included extracting consistent 5-digit zip codes from facility addresses and removing duplicate records where facilities had the same name and address but different NPIs. Next, we attempted to validate and align our dataset with an external CMS hospice facility dataset. To do this, we used fussy matching in Python to account for slight differences in naming conventions. Our matching criteria required at least 90% similarity in facility names, along with an exact match on zip code. Using this approach, we were able to match 34 facilities out of approximately 270 from the NPI dataset to the 84 facilities listed in the CMS dataset. This step helped us assess data consistency across sources and highlighted some of the challenges in working with real-world healthcare provider data. Next slide, please. And then Sarah, I don't know if you're able to play this. There's a video on here. Would you be? Yeah, perfect. Thank you. So this slide shows a demonstration of the sociodemographics and hospice provider dashboard that we created. In this visualization, each county is shaded based on the selected sociodemographic variable, ranging from very low and light blue to very high and dark blue. Overlaid on the map are yellow dots, which represent the number and distribution of hospice providers within each county. The dashboard also allows us to filter across different sociodemographic factors, including marital status, categories such as married, separated, widowed, and divorced, as well as household income and poverty levels. It also includes Alzheimer's prevalence and age brackets like 65 and over and 75 and over. This interactive view helps us explore how hospice provider availability aligns, or in some cases does not align, with underlying community characteristics across Colorado. Next slide.
So after preparing our data sets and exploring our dashboards, we moved into the model building phase. Because the number of hospice providers per county is heavily skewed to the right, we shifted our focus from predicting exact counts of hospice providers in a given county to understanding what factors are associated with the presence of a hospice provider in a county, so on a binary level instead. Our goal was to identify which demographic, socioeconomic, and healthcare-related attributes best explain why some counties have providers, hospice providers, while others do not. Next slide. Once we established our modeling approach, we evaluated performance against a simple baseline. Our dummy model achieved an F1 score of 0.70 with an accuracy score of 0.54, which gave us a benchmark score comparison. Our best performing model improved substantially, reaching an F1 score of 0.80 and an accuracy score of 0.77. We also examined feature importances to understand which attributes contributed most to predicting the presence of hospice providers in a given county, which is displayed here on the right. Next slide. We then conducted feature importance analysis to understand which attributes drove the model's predictions and to explore how performance changed as we adjusted the number of features included in our model. This step helped us identify that the top 6 attributes contributed most to predicting whether a county had a hospice provider or not. Although it slightly underperformed compared to our full model, this did help us identify a smaller feature set to aid in our scoring approach, which we will dive into on the next slide. So using those top 6 features identified from the feature selection analysis, we created a simple scoring system to highlight the potential gaps in hospice provider coverage. Each county received a score by summing the quantile bin values for those 6 attributes, giving every county a total out of 30. And then we compared those scores to the actual provider counts or presence in that county. So counties that had a high score but had no providers in that county stood out as potential areas of unmet need across Colorado. Next slide.
On the next 3 slides, we'll walk through results for a few example counties to illustrate key patterns from our analysis. Starting with Delta County, we see a smaller, more rural population of just over 54,000, with a relatively high proportion of residents aged 65 and older. The model score is 26, the highest of all the counties, and a higher score means potential gaps in hospice care. There's only one hospice provider in the county, resulting in a relatively low provider to Medicare eligible rate. What also stands out here is that several indicators associated with potential hospice needs, such as a high elderly population and a notable veteran population, are all elevated. Overall, Delta County suggests a potential imbalance where indicators of need are relatively high, but provider availability is limited. Next slide, please. In Huerfano County, this imbalance becomes even more pronounced. This is a much smaller county with just over 7,000 residents, but a very high proportion of individuals aged 65 and older. The model score is 25, and notably, there are 0 hospice providers in the county, resulting in a provider to Medicare eligible rate of 0. At the same time, several indicators of need are high, including Alzheimer's and dementia prevalence, as well as the proportion of female householders and veterans. This makes Huerfano County a strong example of a potentially underserved area where the population characteristics suggest a need for hospice care, but no local providers are present. Next slide, please. In contrast, El Paso County represents a more urban setting with a much larger population. Here we see over 30 hospice providers, a lower model score of 18, and a significantly higher provider to Medicare eligible rate compared to the previous counties. Interestingly, while the overall population is large, the proportion of residents aged 65 and older is relatively low compared to other counties. However, the county still shows high veteran population levels and moderate Alzheimer's prevalence. This suggests that provider availability may be more aligned with population size and infrastructure rather than strictly with indicators of need. Comparing these three counties highlights the variation across Colorado, with some areas potentially underserved and others having greater access to hospice care. Next slide, please. Looking ahead, there are several opportunities to expand and improve this analysis. First, we could integrate additional data sets, including race and ethnicity, to better understand disparities in hospice access. We could also incorporate other medical conditions such as cancer, stroke, heart disease, and respiratory illness, which are highly relevant to hospice utilization. Expanding the dataset to include additional hospice facility sources and even extending the analysis to other states could allow for broader comparisons. We also see an opportunity to explore palliative care services and incorporate facility-level patient data as well as at-home hospice care utilization. From a modeling perspective, we could develop a weighted scoring system to better quantify hospice need across counties based on the most important features. And finally, improving the facility matching process between datasets would strengthen the accuracy and reliability of our results. For example, in a quick manual validation, we identified at least one hospice provider in Huerfano County called Sangre de Cristo Community Care that was not captured through our automated matching process. This highlights both the challenges of working with real-world healthcare data and the importance of continued data validation. While our framework is effective for identifying patterns and potential gaps, the results would benefit from further refinement before being used in a real-world decision-making context. Overall, this project provides a strong foundation that can be expanded into a more comprehensive and actionable analysis of hospice care access. Are there any questions?
Awesome. Thank you both so much. That was great. I love a beautiful dashboard like that. We love that at Civic. So many of these presentations are so far above my level of understanding, but I feel my brain light up when I see a nice, pretty dashboard. All right. I will go ahead and give just a couple of minutes. If anyone has any questions, for Erin and Dagmar, please go ahead and type it into the chat, as we've been doing. And we are at the close of our presentation now. So if you have any other presentation questions that have come up for any of our other presenters, please go ahead and add that into the chat as well. And I'll just yap for a couple of minutes to give everybody a chance to get in their final questions. So first of all, thank you so much to everybody for being a part of this presentation today. We really enjoyed having you all here, and thank you so much to our fabulous presenters who presented really interesting information, and were able to put up with my fat fingering away on the keyboards. So thank you all. Here, there is contact information. If you have any other additional questions that come up, like I said, maybe you're thinking about this later on tonight, laying in bed, awake, thinking about it, as I know I will be, and another question comes up, the contact information for everybody is right here on this page. So feel free to reach out. You can connect with us at Center for Improving Value in Healthcare. We are on LinkedIn primarily. We also have an Instagram page, so connect with us on social media to keep up with everything that we have going on. And feel free to join our email list and be subscribed to our newsletter and all that good stuff. Maybe if this sparked any ideas for you and how you may be able to use co-APCD data. Or if you just want to chat with our team about an idea that you may have or a question that you have that you would like to answer, please feel free to reach out to us. You can reach us at our email address is info at civic.org. So please reach out to us, and I will be able to connect you from there to our team to talk about any ideas that you might have. So with that, I have not seen any additional questions come into the chat, so I will give it just another minute or so, and then we will go ahead and give you the rest of the time back. Wrapping up a little bit early, which is unusual for us, but I'm sure everybody appreciates a few minutes back. Maybe finish up your lunch or whatever you may have going on this Thursday. All right. Thank you, Christy, for that comment. Thank you for the cute little emojis, everyone. All right, seeing nothing else come in. Again, another big thank you to our presenters for your really, really interesting presentations today. It is always a thrill for me to learn about how CIVHC data is being used and what kind of projects it's supporting. And so important and so interesting. So I really appreciate everybody's time today. And with that, feel free to reach out if you have any additional questions or anything else. And I will let you have the rest of your afternoons back. But thank you so much again for joining us today. Have a great rest of your Thursday afternoon.